The chairpersons for the session are Dr. Thirumalai Velu and Dr. M. Sharma. We are going to introduce our speaker first. Professor Dr. Robert Behar, Professor of Neurosurgery Emeritus, University Medicine, Marburg, Campus Fulda, Department of Neurosurgery. 2007, he is Secretary General European Skull Base Society and Treasurer of General European Skull Base Society. From 2016 to 2018, he was President of European Skull Base Society, Member of German Skull Base Society and Honorary Lecturer of Schormann's Lecture 2022, Member of German Cancer Society, Master in Spine Surgery of German Spine Society, Member of German Neurosurgical Society, Member of Advisory Board of International Center of Hearing, mentored Auditory Brainstem implant program in many centers across the world, including MERF in 2005. Started this program with Professor Muller in 1995, in Würzburg, University, Germany.
Yes, thank you. And good day to everybody here. With this medal around my head and my neck, I will speak a little bit easier, I think. So, I'm not going to talk only about the pediatric ABI, but I want to focus a little bit on the ABI as a treatment for deaf people with injured or destroyed cochlea and or cochlear nerve. And I want to draw your attention to this treatment because I think it's makes very much sense and has a great future. So how can I continue? The next slide. So now I'm ready. Let's begin with cochlear implants. In the 1970s, very famous people, they stated cochlear implants could never restore any hearing, but single sound. Speech understanding would never be possible, and open set speech understanding will never be reached, and CI may improve hearing of environmental sounds. So the expectations at that time were low. Reality now is, however, deaf children hear almost normal and can go to regular school. Deaf adults are reintegrated into normal life and work, and cochlear implant patients have an almost normal life. So that's an A. Okay. What's about ABI? This is Bill Hitzelberger, who implanted the very first ABI in 1979 in Los Angeles with his first patient. And at the beginning of ABI, some people stated ABI could not be better than a single channel cochlear implant. Speech understanding would never be possible. Open set speech understanding will never be reached. ABI only supports lip reading and may improve hearing of environmental sounds. So expectations were low. But one of our first patients, Sylvia, operated in 1998 in Warsaw by myself. He was an excellent performer and used his telephone. Okay. ABI indication and candidacy. So the main indications for ABI, you probably know, is deafness by tumor in neurofibromatosis mainly, then deafness by infections, meningitis for example, and what's very important, especially also in your country, deafness by inborn diseases. That means aplasia or dysplasia of the cochlea or the cochlear nerve or other sensory diseases. The implant, which I use, has a CE mark, of course, and it is allowed for tumor cases from 1 year of age onwards, non-tumor cases of 1 year of age onwards, and for tumor cases from 15 years onwards, and is certified for 1.5 Tesla MRI with or without a magnet. So this is the implant. You can see here the processor, which is worn behind the ear, and the stimulator, receiver stimulator. This here is the coil which transmits information from the processor to the receiver stimulator. It's just like a CI, And this is the stimulation probe with 12 contacts. And this here is very important. It's a test electrode with 4 contacts, which is used prior to the implantation of the stimulating probe. I will come to this later on. Some words to candidacy and postoperative outcome. In my experience of now 25 years or so, I found that there are some preoperative criteria. So the patient should have a little additional handicap. The deafness before implantation should be short. There should be a free brainstem. That means, especially in tumor cases, no other lesions, tumors around or in the brainstem. The patient, and that's very important, should be motivated and intelligent. And I think this is of utmost importance, is that the caregiver support for the patient. And if these criteria are fulfilled, so there is a good possibility to get a good result. And there are intraoperative criteria. The tumor resection, if there is a tumor, should be uneventful, so less bleeding also. You have to do a gentle dissection and resection, less coagulation. You need clear landmarks, and the lateral recess should be normal. That means it should not be compressed or distorted, and there shouldn't be any other expectation of the stimulating electrode. Now it's removed. You have got good recordings. This is the stimulating electrode with the mesh on the back. It's cut a little bit so that it fits into the lateral recess. You can see it now. This is again vein, largely widely opened lateral recess. Here the cranial caudal nerves, and then you put the electrode onto the area of the cochlear nucleus, not squeeze it into the lateral recess. This is, I think, important. By this squeezing, you may inject the cells of the cochlear nucleus, and this may reduce the outcome. So when it is at the right place, we use a little bit of research cell, and we do a pre-fixation with fibrin glue, a few drops of fibrin glue. You will see in a second. Okay, and then we use pocket steel just to improve the fixation.
It was indeed a thought-provoking lecture. It has really stimulated our thoughts regarding the pathway of speed, the hearing. Like from cochlear implant, we have migrated to ABI. Now, probably in future, maybe lateral meniscus or idiogenic body implants. What do you see the difference? Why is it that as it goes above, the chances of hearing is lesser?
Yes, I try to give it in my recommendations. I think when ABI started, let's say, I must say started again, because the first was in 1979, but this was only a single channel, so to say. But when it started with multi-channel ABIs in the early 1990s, I think the surgeons had not the idea how to implant the ABI very safely and precisely. At that time, we did not have such test electrodes to find the exact place of the cochlear nucleus. And after many ABI implantations I did, I know that when you just look for the anatomy, you may be wrong. And you have to correct the implant site with this test electrode I mentioned. So I think this is very important, and with the introduction of this test electrode, the results are getting better. This was my impression. And of course, with the surgery and let's say the gentleness of the surgery. It is not good, I mentioned it already, that the opening of the lateral recess is only a little bit and then you squeeze in the electrode and that's it. You have to open it widely enough and to see it and to place it very gently onto the cochlear nucleus area and then do the measurements. And the second thing is, of course, the stimulation, let's say the electronics, they improved also, and with the CIS strategy of stimulation, this was also a breakthrough and improved the results. So it is, as it always is in life and it always is in medicine, it's a puzzle, you know. Many parts come together and then the results will improve. That's what I think about it. Thank you.
And does myelination take a role in the implantation in the brain? Myelination. Myelin, the myelin which runs over the nerves, does it have a role in the
myelination? The myelination, okay. I can't say anything to that because, you know, the nerve is absent. You don't, in most cases, you don't see a nerve. Because if you see a nerve, then probably you should go for a CI, if it's possible. I hope I get your question correctly, but
No, this is just to ponder over how early we can do an ABI. Earliest ABI in your series, in children with cochlear nerve aplasia, which is the earliest age.
Okay, no, I understand. I'm sorry. The acoustics are a little bit difficult here. So, yes, the implant is certified for 1 year and for the non-tumor cases. I did the youngest children I operated was 1 year and 6 days. But this is always a little bit more difficult than in the little elder children. So I would recommend to take 1 year and a half. This is a good time. It's also, you know, it's also problematic for the anesthesia in these small children, in very little children. So if it is, let's say, it is possible with 1 year, but it's more difficult and you need more experience. But with 1.5 years and let's say 1.5 to 2 years, it's easy. So I cannot tell you, from my experience or from the literature, I cannot tell you if the results are better when you implant at 1 year or at 2 years. What we can tell with our study and others too is that 3 years is some threshold. If you are below 3 years, it is in most cases a better result than above 3 years. So I hope I answered your question.
Thank you very much, Professor Robert. It was indeed a great lecture. Thank you very much for having come here.